Let's kick things off with a term you might have heard before: parapsoriasis. It was introduced back in 1902 by a dermatologist named Brock. But the definition of this condition has been up for debate ever since. You might have come across the term parapsoriasis en goutte. Well, that one's actually been phased out because it's specifically used to describe pityriasis lichenoids. Then there's parapsoriasis en plaques, which sounds pretty straightforward, but here's the catch: it's tough to define. The lesions don't fit neatly into the category of plaques. They can range from small to large patches, making them harder to classify. What's interesting is that since the 1990s, large plaque parapsoriasis has often been considered an early stage or even a precursor to mycosis fungoides, a skin lymphoma with an indolent course and a good prognosis. On the flip side, small plaque parapsoriasis is a separate entity altogether, and its course is generally benign, rarely progressing to mycosis fungoides. Now let's talk about who gets small plaque parapsoriasis. It's more common in middle-aged and elderly individuals, but it can certainly affect children as well. In fact, it most frequently presents in the 5th decade of life, that's around age 50. Interestingly, this condition shows up across all racial groups and geographic regions, making it something seen worldwide. And when we look at the numbers, we see it affects males more often than females, with a 3-to-1 male-to-female ratio. The exact cause of small plaque parapsoriasis is still a bit of a mystery. What we do know is that it involves sparse lymphoid infiltrates in the superficial dermis, mostly made up of CD4+ T cells. In some cases, T cell clonality, which means identical T cells, can be spotted in the skin infiltrates, and sometimes it even appears in the blood. However, interpreting these findings can be tricky, and there's still a lot we don't understand about their significance. Genetic studies often reveal an oligoclonal or pseudomonoclonal pattern in most patients, meaning the T cells aren't exactly identical, but are more similar than you'd expect. Despite the term plaque, small plaque parapsoriasis doesn't actually consist of plaques, but rather patches with fine, delicate scales. These lesions are chronic, and while they're typically asymptomatic or only mildly itchy, they can change over time, waxing and waning before becoming more persistent. Some patches might even regress on their own, either spontaneously or with treatment, but don't expect this to happen quickly. This process could take months or years. The lesions can appear all over the trunk and extremities, or they can be more localized, often in sun-protected areas. They're usually round to oval, under 5 centimeters in diameter, and may have varying degrees of erythema and fine scaling. Interestingly, some patches even have a yellow tint, which used to be referred to as xantherythrodermia perstans. One notable feature is digitate dermatosis, where the lesions become elongated and finger-like, often on the flanks, sometimes over 10 centimeters long. While progression to mycosis fungoides is extremely rare, with fewer than 20 cases documented, it's something we always keep in mind. When we look at small plaque parapsoriasis under the microscope, we see mild spongiotic dermatitis with focal parakeratosis. The presence of lymphocyte exocytosis, where lymphocytes move into the epidermis, can vary, but it's usually there. However, we don't see Potrier microabscesses or atypical lymphocytes, which would point to more severe conditions. Interestingly, haloid lymphocytes can sometimes be found in the basal layer. Diagnosing small plaque parapsoriasis is all about correlating the clinical presentation with the pathology. Other tests don't add much value here. Differentiating it from large plaque parapsoriasis relies mostly on clinical features. We also need to rule out other conditions. For example, pityriasis rosea has a herald patch and resolves on its own within a few months, so we can distinguish it from parapsoriasis that lasts longer. Psoriasis and secondary syphilis can be excluded through clinical and serologic testing. Other conditions, like pityriasis lichenoids, whether acute or chronic, are also part of the differential diagnosis. These present with smaller, more widely distributed lesions, and of course we need to consider drug eruptions that might look like pityriasis rosea or mycosis fungoides, and make sure to rule those out. Now, when it comes to treatment for small plaque parapsoriasis, there's no gold standard approach. Most recommendations come from case reports and anecdotal evidence, so it's not as straightforward as some other conditions. The good news is that the risk of progression to mycosis fungoides is very low. So many patients can opt for monitoring without treatment if they prefer. For those who want to take a more active approach, The most common treatments include topical corticosteroids and narrowband UVB therapy. Clinical improvement is common, but recurrences do happen, so this isn't a one-time fix. And here's the lingering question. Does phototherapy help prevent the progression to mycosis fungoides? Well, we still don't have a definitive answer on that.